Let's take a look at kinesiology taping for mechanical support. So coming back to our intention, what is it we're trying to achieve for our client? And this is where we've done our subjective and objective assessments. And one of the key things we need to achieve in the first instance to help our clients to move better is to create some type of a mechanical support within our treatment to either help them have some stability, to prevent over movement or over mobility, or for example to offload something while it strengthens or while it comes out of that acute period. The clues that we get in that assessment are where we're talking about or thinking about things like support, offloading, holding something, where we've got hyperextension and where we want to prevent that, where we want to add stability to a joint, or where we want to help something track in a better or more fluid way. They're all the indicators and all the signs that would be pointing us towards providing a mechanical support with our taping. There are 3 different mechanical supports that we can do with our kinesiology tape that we will look at today. One is positional, so helping something to get into the position, our target position, or our pain-free or our better movement position. So all about creating that position or hold with the tape. The next is offloading tendon. So if we have a tendon that's overused, that is tender, that is inflamed, and it's not quite getting that chance to rest, to heal, to strengthen, then we can use that tape to offload the amount of pull or pressure on that tendon. And finally, we're going to look at movement limiters. So if someone over moves, if they're hypermobile in a joint or in a plane, and that is creating a negative effect or is preventing them from moving forward in terms of their rehabilitative movement, then we can again use that kinesiology tape to help limit that movement, which in itself is not going to fix the problem because the client needs to create that strength, create the stability where they don't have it. But it might stop them locking out joints and creating the pain that they may be feeling that is stopping them from moving forward in terms of the movement or strength training that they need. Let's take a look at positional mechanical support. So going back to our module on the tape, remember we lose the recoil, so it becomes a hold when there's greater than 70% tension. So this is all about putting heavy tension on the active portion of the tape. We simply put it in the position and then hold what we're trying to achieve. That leads nicely into the process. So we need longer anchors, because if you think about this, if we've got a real heavy pull on that middle of the tape, the anchors need to be holding tighter than if we have a light amount of tension for, say, an inhibition or an activation. So our anchors are always much longer with this type of a taping. So we anchor, long anchor, no tension, no stretch. Secondly, the active piece of tape. So this time it's not about stretching the tissues, it's about moving into the desired position, whether that be pull a shoulder blade back and down, or putting a hamstring or the pelvis into the position that you want. We then apply heavy tension on the tape and lay it down directly over the target tissue in that held position. Then we simply anchor with no tension and no stretch in the tissue, creating a hold of the position our client was put in. Let's look at the first example, where we're going to look at someone with a protracted or rounded shoulder and how we can use the kinesiology tape to get a mechanical hold into a better, more neutral position. Remembering we need long anchors here, so we need quite a long piece of tape for those long anchors and then to come across the shoulder. So here I'm just palpating the client's shoulders and also giving her an indication as to where she needs to put her shoulder. So I'm going to first of all create an anchor, which is a good 4 or 5 inches long, and I'm going to start that around the thoracic spine and lay a good 6 inches of tape down on the back of the shoulder and over the shoulder blade. Now the active piece of tape, so I peel back that middle 6 inches and put a heavy stretch. I get my client into that position, externally rotating the arm, bringing the shoulder back. And I lay that tape down right across onto the chest and then lay the anchor down with no tension. Next up is offloading an inflamed or painful tendon. Okay, so key here is taking pressure off. So it's about creating a tension or a push back towards the attachment of that tendon so that it takes some of that pull from the muscle off the tendon, allowing it a chance to heal, to rest and become desensitized. So here we've got the active piece of tape. We peel back the middle of the tape first. We put that tendon on stretch. We then add heavy tension onto the middle piece of tape, and our direction of laying that tape is downwards and towards the attachment of that tendon. So that what we're creating is a push back towards that attachment point and offloading some of the pressure that that tendon is on. We then get our client to completely relax the part of the body we're working on, and we lay the anchors down with no tension on the tape. Putting that into practice, let's look at how we use this taping technique to offload the tendon at the lateral epicondyle of the elbow. So for a tennis elbow tendon problem. So here we need a piece of tape that's maybe 4 or 5 inches long, because the middle piece of the tape, or the active piece, is only going to be 1 to 2 inches. Peel back the tape, put a heavy tension on the tape and get your client to flex their wrist. We then push that tape down and towards the attachment at the elbow and simply anchor with no tension. Now, when it comes to limiting movement, this is a little bit different. So if we think about a joint that we're working on that goes into hyperextension, what we're trying to do is create a mechanical pull that prevents it or makes it more difficult to get into that hyperextended position. So it's all about getting that joint into a flexion, and what we're going to do is add medium amounts of tension on the tape, because what we want to happen is that as that joint moves towards extension, we're getting that strong mechanical hold. So first up, we want to anchor the tape at one side of the joint with a good 5 to 6 inches of anchor. We want no tension on the tape, no stretch on the tissue. Next, we want to get our clients to flex the joint that we're working on. We then add a medium amount of tension to the tape and anchor on the other side with no tension on the tape on the anchor. So at this point, what you've created is a tent, because the tape will not have touched the back of the joint because it's in flexion. Then when you get your client to extend the joint, you can then rub down the tape, and that will result in a heavy tension on the tape at the active part where it's connected with the skin. It's much easier to see in practice what is meant by the process for this type of a taping. So we're going to look at hyperextension in the knees and how we apply that tape to achieve that mechanical support. So we cut a piece of tape, maybe 15, 16 inches long. We're going to apply the first 6 inches of that tape as an anchor below the knee. So no tension, no stretch. Now we're going to peel back the active part of the tape, which is another 5, 6 inches. Get your client to flex the knee and then lay the tape down across the other side of the joint. So you can see that tent that I was talking about. And we just lay that tape down with no tension on the other side as the other anchor. Now, as you can see that the client has extended, now in extension we can rub that tape down and make sure it sticks well, which results in a heavy tension at the back of the knee. So there's some other considerations with the mechanical taping that we haven't had to consider as much with the other types of taping. One, we're using far greater levels of tension, so that's going to have a much greater pull on the tissue. So pull on the tissue can also mean more of an irritation. So this is the type of taping that might irritate the skin, and is certainly not something you want to do as a long-term solution, but can be really, really useful in that transitional phase as you develop the strength with your client to be able to create that support themselves within a joint. That itself leads on to an additional contraindication. Thin, fragile skins, especially in the aged population, I would say I would not advise using mechanical tapings. The pull on the tissue is too great and you might end up damaging that thin skin that they have. It becomes even more important to educate your client on removal on the tape and how to do that. Again, maybe post hot shower using one of the removal techniques that we've talked you through in the taping module. Finally, really important that you use longer anchors. One, in terms of longevity of the taping, but two, it reduces the pressure. If those anchors are short, with that heavy tension on the active piece of the tape, you're going to have a lot of pressure on those anchors. So that's a simple way of spreading that pressure out on a wider part of the skin. So finally, to recap, we have 3 ways that we can create mechanical support with kinesiology tape. 1, positional, so tape to hold or to stabilize. 2, to offload inflamed tendons or tissues. Or 3, to help limit movement in joints where there's too much movement or hyperextension.